Uh, and last time when I started talking about some of the things, there were some controversial issues. कुछ चीजें शायद मैं एक्सप्लेन नहीं सही कर पाया, कुछ आप लोग ने परसीव गलत किया, इसलिए मैं बार बार कहता हूँ कि जब समझ ना आए तो रोक देना, पूछ लेना, कुछ मैं क्लैरिफाई कर दूंगा, और अगर मैं क्लैरिफाई नहीं कर पाया तो मुझे डेफिनेटली फीडबैक दो ताकि मैं सेकंड टाइम उसको मजीद एलैबोरेट कर दूं, सो दैट यू पीपल वोंट हैव एनी प्रॉब्लम्स इन understanding the concept. So just a small thing before we move forward. Whenever you are attempting a question, there are two types of the situations. One, absolutely clear question and a clear answer to it, which is available in the books. Now, there are few things which unfortunately different books and different literature gives a different description of a situation. Like there may be a description, discrepancy in the definition of some of the things. And usually those things then do create complexity. The best way is don't worry about too much about it. If you read one book and there is one definition there, and if you read another book, there is another definition there. So just remember one of them and put a reference there that this is the definition from this book. That is the best way of doing it. So चीजें थोड़ी सी clarify हो जाती हैं. So references are very, very important. So when you are saying that this concept is related to this, and this is what the definition is, and this is what is mentioned in this book, textbook, that gives a lot of authenticity. So even if there is a discrepancy in a definition or data or epidemiological studies or something like that, if you have a reference, that is acceptable. So basically, again, evidence-based practice means that we should have evidence for something which is happening around us, and we should follow the evidence-based practice. So this is important for you, all of you. Again, even then, if you feel that there is some difference somewhere, stop me, challenge me, ask me, and I'll be happy to respond. I'm sure you will be clear about it, right? Okay, so shall I move forward, or should I wait for few people to join in further?
Oh, sir, आप start कर लें, I think.
Okay, let's start then for today. एक बहुत मशहूर शायर थे मोहसिन नकवी. I personally knew him somehow or the other, so he was a very nice person. और उनका एक ये छोटी सी कथा है. जल रहे हैं बदन दर्द की धूप में, जिंदगी ढल गई जख्म के रूप में, दिल में कोहराम है तीरगी आम है, एक निगाहे करम ए हबीब खुदा, अल मदद मुस्तफ़ा, अल मदद मुस्तफ़ा. And whenever we are describing various situations, if we are inclined towards our religion, we always seek the help of some of these things. So I hope it gives you a peace and a way to move forward. Okay, let's start further. So today, the question was confidentiality. Actually, the question in the exam related to confidentiality are asked in a multiple way, but basic concept of confidentiality remains the same. So when you are attempting a question where it is related to patient or theoretical, they are almost the same. So there was one question in the exam that a person you are treating was suffering from schizophrenia, and one of your friend came to know that she is your patient. His brother is getting married to that girl, and he asks you what is wrong with her, what kind of medication she is taking, and what do you think about the marriage. So professionally speaking, as a professional, even if our closest possible relatives, even if my wife wants to ask me anything about my patient, I should not break the confidentiality. So generally, if an institution person A holds information about person B, the person C cannot obtain that information in the normal course of events without the consent of person B. It's absolutely clear that I cannot disclose any information to anybody about any of my patient. That's absolutely clear. Unless or until there are few things where I can break the confidentiality, और उसके बारे में भी सवाल है, so I will cover that up later on, but it is absolutely black and white. Most people consider health information to be highly personal and therefore need to be confident that their privacy will be protected whenever they use a health service. Clear and open communication between the health service provider and health consumer is an integral to good privacy. So no doubts about it that any information when you are seeing somebody, even if you have assistant doctors working with you, even if you have somebody who is a psychologist or a mental health professional or a social worker sitting in a team setting and seeing the patient, none of them are supposed to talk about the patient to anybody. It's absolutely clear. So I will repeat it again. Generally, if a person A holds information about person B, then the person C cannot obtain that information in the normal course of events. So in this situation, when one of my friend asked me about one of my patient, how do I respond to it? I will clearly say that how do you know that she is seeing me? First thing. Or agar wo कहें supposedly like they themselves told us that you are the treating psychiatrist. Even then I will say, okay, fine. If you have that information that I am seeing that person, then my respond to it is that unless or until that person himself or herself comes with you, one, I can disclose whatever they feel comfortable with it. Second, best option, written informed consent. So if you feel that that person cannot come and see me with you because you people are not related as such otherwise, then take an written informed consent from the person to disclose the information, and then you can come back to me and we can talk about it. Otherwise, I will not be able to tell you any information. Even to an extent, I will not admit and accept that I am trying to treat that person and that person is under my care. So confidentiality is the key in our psychiatric practice. Well, it should be the key in any practice, but still it is the response. I hope I am very clear about it. Any questions, anything? I won't be able to see the chat box unless or until I have a break. So please stop me and ask the question. Now, another question came in the exam. What is autosomal recessive gene and what are the examples of autosomal recessive gene? There was a discussion going on with some trainees, and one of the things which surprised me actually a lot. So the resident said to me that uh, blah blah person said to me that there is no point in attending the lectures or listening to other people. The only thing that matters to pass the exam is if you study and study and study. There is no doubt about it that you have to study to pass the exam. The advantages of these lectures, whatever we are taking or any of your senior person is taking, is two things. One, when you are reading a book, there are few things which are not probably as clear as they should be. And sometimes it is difficulty in having an understanding about the concept. And two, the experience teaches you a lot. So you know that these things are important and these things are not very important. So you try to cover that. And above all, the clinical experience with the application of the theoretical knowledge matters the most. So if your senior is teaching you something, always beneficial. Whenever I go to a conference, I try to attend most of the lectures and I try to sit there even at this point in time because there is always something that you learn new in various conferences and meetings and lectures and all that stuff. So, coming back, autosomal recessive. If the father is a carrier and the mother is a carrier of any, again, genetic abnormality, the possibility of having affected child is in 4 is to 1. So NB, NB, two are the carriers. So NN is one combination, NB is the other combination, NB is the other combination, and one combination is BB. BB is affected. So NN, NB, NB, BB. This is the basic theoretic theory behind the autosomal successive generation. So if both the father and the mother are the carriers, the possibility is 1 in 4. If only the mother is carrier and the father is not a carrier, then the possibility is further less. And if none of them are the carriers, even then there is a possibility of having a genetic abnormality because of certain processes, which we may talk some other time. What are those things? Autosomal recessive inheritance, example of the recessive conditions: 1, sickle cell disease, cystic fibrosis, Batten disease, congenital deafness, phenylketonuria, spinal muscular atrophy, recessive blindness, and maple syrup urine disease. Of these, all the diseases, probably they are all complicated and unfortunately they are difficult to treat and manage, but these are some of the conditions. And most of them have psychiatric symptoms: maple syrup urine disease, recessive blindness, spinal muscular dystrophy, phenylketonuria, Batten disease, cystic fibrosis, and sickle cell disease. What are these diseases? I don't want to go into the detail because they were not part of the question. But if there is some important question, I will come back to you. Factors affecting intelligence. Now, most of the time, the research says that intelligence is inherited. So if my mother is having an IQ of 80 and my father is having an IQ of 120, the possibility of me having an IQ of 100 or more, but I can have an IQ of 120 as well, or maybe more than that, an IQ of low IQ as well, 80 and that, as I mentioned in my recessive gene expression as well. So intelligence is basically inherited. But there are factors which can affect intelligence. 1, hereditary and the environment. So if somebody with a low IQ is born to the high IQ people, the environment is such that people will talk about and discuss about some issues, matters in a high intellectual level, and the child learns with it. So the IQ may be better. Then second, age. Usually with the passing age, when if the environment is conducive, the IQ can be enhanced. Race and nationality. Some of the races by birth are very intellectually good. I have high IQ. Some races have low IQ. Health and physical development. If your nourishment is fine and your development is normal and healthy, you don't eat fast food, burgers, blah, blah, blah. You use healthy food. You have balanced nourishment. You have all the multivitamins and requirements which are required by the body in the form of a diet, not pills. Then, of course, it affects the IQ. If those things are deficient, the IQ may go down. Culture. Some of the people belonging to a specific class of culture, they definitely have an impact on IQ. So a person with an average IQ may behave as very much highly intellectual person if the culture promotes it. But unfortunately, if the culture is against it, that IQ can be lower as well. Parent-child interaction. That is the grooming period when the child is from 3 months age up to the, again, age where the brain processes and the synapses are complete. And if the learning and other methodologies opted to teach and train them are appropriate, it definitely have a good impact on IQ in the longer run. Social and economical conditions. It is always said that poor socioeconomic conditions lead to poor IQ and poor outcome. Determinants of intelligence, culture, difference in academic performance between American and Asian students are found from first grade through high school in mathematics and reading. May be related to difference in the cultural attitudes towards ability and effort. Stability of intelligence, IQ stays relatively steady over the course of life, right? So the IQ remains 70 if it is 70, but it can modify, improve to an extent of expression and other things, because IQ is not just one thing, memory, it has other parameters as well. And you people probably know that. We may cover ways and we will cover this topic as well. Is it clear? Anybody, any questions? No?
No.
Sure? Should I keep rolling up? Okay, let's move forward. So, Maslow's theory of self-actualization, a very common question asked previously. Now it has changed a little bit, so they are putting some additional things into this pyramid to make a question on a clinical basis. And I don't have to go through the basic thing, but I will just forward it by reading it. So according to Maslow, the hierarchy of needs includes one, physiological needs, which includes food, water, warmth, and rest. Then there are security needs, sense of safety and security. Then there is belongingness and love needs, intimate relationships and friends. Then esteem needs, prestige and feeling of the accomplishment. And then self-actualization. Most of the psychology books quote, again, the American person, Martin Luther King, and Mahatma Gandhi as one of the self-actualized person. धोती पहनते थे, सादा रहते थे, जमीन पे सोते थे और लोगों के लिए काम करते थे. It is just to describe it. It never means that these are the only two examples, because these are quoted in the Western books. There are multiple other examples, and you can quote any one of them, where you are not actually concerned about your own needs, but the well-being of generally the rest of the human race. That is a self-actualized state. पहली स्टेट ये है कि जी मुझे खाना मिल जाए, रोटी मिल जाए, सोने की जगह मिल जाए. फिर दूसरी, अगेन, मैं सेफ रहूं, सिक्योर रहूं, मेरे घर के आस-पास कोई चोरी डकैती खतरा ना हो. And then I have a good wife, I have a children, I have friends, and I live happily. And then you try to move forward with prestige of feeling accomplishment. Now, it's not necessary that you should have all those needs in the same pyramidal structure. Some people may be, again, having belongingness and love needs right from the beginning, and they are moving forward with their esteem needs and self-actualization. Some people may start from the self-actualized state and they never have other issues related to them. So it can, this pyramid, in the normal human beings, anybody can fall in any of the categories. There are parameters associated with it, but not as such a compulsion that you have to follow the steps and then up to the self-actualized state. Then the question was, what is the difference between classical conditioning and operant conditioning, and what is behavior therapy? Some of the concepts of the behavior therapy. So classical conditioning versus operant conditioning. Looks like natural bodily reactions and emotions that we can't control. Sight of pills, even it is a neutral stimulus. Pills gives you stomach ache, and sight of the pills becomes conditioned stimulus that makes you feel sick. देखते साथ ही तबीयत खराब होनी शुरू हो जाएगी. Must involve a neutral stimulus, the unconditioned stimulus. Becoming a conditioned stimulus, With classical conditioning, the response always comes after the conditioned stimulus. So US plus CS is again CR, conditioned response. Behavioral choices that we make, actions, operant conditioning. So accidental response, reinforcement, and deliberate response. They are all connected to each other. Behavior is not associated with a conditioned stimulus. Behavior is based on past experiences that either encourage us to repeat a certain behavior or discourage us. मुझे एक दफ़ा पता चल गया कि मैंने इम्तिहान में पढ़ाई नहीं की थी, मैं फेल हो गया था, मैंने लर्न किया और वो चीज़ मेरे ऊपर इम्पैक्ट करती रही. दिस इज ऑपरेंट कंडीशनिंग. The behavior therapy, ABC, antecedent, behavior, and consequences. So, antecedent is prompting, modeling, feedback, and goals. Behaviors are desired or undesired, and consequences are positive reinforcement, negative reinforcement, punishment, or extinction. There is again nothing complicated about it. Remember this, it's a typical theory question. Is everybody fine? Okay. So I thought that something came up. Okay. Now, what are the psychometric good test or good scales? So the question was asked about what are the qualities of a good psychometric scales. It was asked in 2, 3, 4 times with a different again stem, but the answer remains the same. The characteristics of the good test. 1. Test preparation activities which promote quality, long-term learning are appropriate, even essential. Good test taking skills and appropriate content learning can reduce the likelihood that extraneous factors will influence students' test score. The various characteristics of good tests are: 1. It can be tried out and selected on the basis of difficulty level and discriminating power. So when you are administering a test, you can be sure that this person, if his actual score is 81, it will come on this scale as 81 as well. Directly related to the educational objectives or the research purposes. It should possess description of mere behavior in realistic and practical terms. सिर्फ theory काफी नहीं है, actual उसकी practical application available हो और easy to understand हो. Contains a sufficient number of test items for each measured behavior, concerned with important and useful meta, comprehensive, brief, precise, and clear. 4 qualities are most important. The test should be comprehensive, so it should be able to understand everything related to what we are asking. Like schizophrenia, then we'll be able to assess every facet of schizophrenia with the test. It is brief, so the person is not taking hours and hours to fill it up. It should be brief, means within 45 minutes it should be completed, ideally speaking. Well, most of the time it never happens. Precise. So whatever the questions are, they're absolutely clear to me. I can respond to them, and the answer is absolutely calculatively decided and clear. So a characteristic of a good test are validity, reliability, practicality, administrability, comprehensive objectivity, simplicity, and scoreability. Usually, these are 7 items. Even if you write 4 of them, it is good to go. Validity, reliability, and practicality. If you mention 3 of them, they are important, but administrability, comprehensive objectivity, simplicity, and scoreability. So I can calculate the numbers and put forward the numbers that I have given test to 100 people, and the scores were ranging from 22 to 100, right? Scoreability. That is important. So these are the characteristics of the good test. So any question where you are asked about a test, the qualities of the test, or what are the features of the test, what are the important parameters in developing a tool, a psychometric tool. These are 7: validity, reliability, practicality, administratability, comprehensive objectivity, simplicity and scoreability, right? और इनको मुख्तलिफ नाम भी दे सकते हैं. Well, नाम मुख्तलिफ हो सकते हैं. Okay, there are a few things in the chat so I can see them. No, everything is good. Okay, let's come back. Okay, now definition of abnormality. I have attempted this question 3 times, and every time I was thinking that something is different. Again, from the various resources that I was picking up this information, the answer was variable. This never means that any of the specific definition was wrong. It was the reference that I needed to quote. One of the comprehensive definition of abnormality that I was able to find is this one. What is abnormal behavior and why do we study it? Definition. One abnormal behavior is defined in terms of relative discomfort of a person, which leads them to seek help from a professional. 2, statistical norms. Abnormal behavior is defined as behavior that deviates from the expected norm. वो जो बेल शेप्ड कर्व है उसके जो मेजॉरिटी पैरामीटर्स हैं उसमें 68.7 या वो जो भी मेजर एरिया है बेल का, 1 standard deviation, and then 1.5 standard deviation, and then 2 standard deviation. If something is around 2 standard deviation, there is no doubt about it that statistically it is abnormal. If it falls within the bell, in 68% of the cases, it is normal. Abnormal behavior refers to behavior which is considered deviant from what is considered normal. Like again, I always give an example that girls wears skirts here and it is considered to be normal. But if some girl is wearing a skirt in Pakistan, which usually girls do wear skirts in Pakistan, then that is considered to be abnormal in general population. Although it is not abnormal as such if they are in the Western country, but it is considered to be abnormal in Eastern country. So it can be normal in certain circumstances and it can be abnormal in certain circumstances. So behavior which is considered deviant or what is considered normal. It also refers to behaviors that are maladaptive. Now, maladaptive is again a different word, and every person has a different meaning associated with maladaptive. So there is a wide range of definitions available. There are 4 Ds which explain abnormal behaviors. Ones, deviance, different, unusual, and extreme. Deviance. Distress, unpleasant, upsetting for both person and others. Dysfunctional, interferes with person's daily functioning. Dangerous, dangerous for the person and others. Carrying a gun is considered to be normal in certain parts of Pakistan. So without a gun, people are not considered as man, right? But carrying a gun in Lahore will be dangerous and people will consider it to be abnormal. So you should remember that in abnormal and normal definitions, deviance, distress, dysfunctional, dangerous is always considered with perspective of the situation as well, right? Environment, culture, so many other factors. Clear? Any question? No question. समझ आ रही है या किसी को समझ नहीं आ रही? अगर नहीं समझ आ रही पूछ लें. आगे चलते हैं. IQ remains static throughout the life, but EQ, emotional quotient, is variable for which the person's actually day-to-day interaction in normal life situation varies. So how do you define IQ and EQ and what are the parameters differentiating them? So IQ, is basically a number representing person's reasoning ability. IQ stands for intelligence quotient, mental age over chronological age into 100 ratio, involves the knowledge and skills we acquire throughout our life and our ability to reason, solve problem, understand abstract information. This is IQ. Now EQ. EQ is ability to perceive, evaluate and control emotions. Emotional quotient is the ability to perceive, evaluate and control emotions. EQ stands for emotional quotient. There are four components: perceiving emotions, reasoning with emotions, understanding emotions, and managing emotions. So IQ at one end is the reasoning ability, and EQ at other end is related everything related to emotions. How do I perceive emotions? How do I reason them? How do I understand them? And how do I manage them? Emotional management is EQ, and IQ is to process the information. Main difference. याद रखिएगा. I hope I'm clear. यूं ही रंजिशों में गुजर गए, कभी वो खफा कभी मैं खफा, चाहतों के मोड़ पर कभी वो रुका कभी मैं रुका, वही रास्ते वही मंजिलें, ना इसे खबर ना मुझे पता, बस अपनी अपनी अना में गुम, कभी वो जुदा कभी मैं जुदा. Unfortunately, the reality of life. Okay, now there was one question, and it's an old question. So if I'll be the examiner, I won't ask this question, but because it was in the exam question and people are still using ICD-10, although I don't feel that we should use ICD-10 anymore, because of the fact that it's an old ICD-11 is there, so we should quote, and theoretically speaking, we should quote ICD-11. There was one more question related to ICD-10. The question was, what are the diagnostic classification systems available? Why it is appropriate to use ICD-10 in Pakistan? उसका जवाब मैं अभी आपको दे देता हूँ. So, diagnostic criteria for depression, सारा theoretical सवाल है, but still I will just cover it. ICD-10 uses an agreed list of 10 depressive symptoms. Key symptoms are persistent sadness, loss of interest, fatigue or low energy. One of these most days, most of the time for at least 2 weeks, if any present, ask about associated symptoms: disturbed sleep, poor concentration, low self-esteem, increased appetite or poor appetite, suicidal thoughts or acts, agitation or slowing of movements, guilt or self-blame. The 10 symptoms then define the degree of depression, and management is based on particularly for these degrees. Mild, fewer than 4 symptoms is mild. Fewer than 4 symptoms is mild. Mild depression, 4 symptoms. Moderate depression, ऊपर की 10 की लिस्ट में से 5 to 6 symptoms if present, it's moderate. Severe depression, 7 or more symptoms with or without psychotic symptoms. Symptoms should be present for more than a month or more, and every symptom should be present for most of the day, every day. These are important parameters. 4 हफ्ते से ज़्यादा 4 हफ्ते हों, हर दिन हो, हर वक्त मौजूद रहे, कभी गायब कभी आ जाए, no. Persist करें. Up to 4 symptoms, mild. 4 to 6, 5 to 6, moderate. 7 and above, severe, with or without psychotic symptoms. And ICD-10 classify them as F32. Now ICD-11 has changed the codes, so they are different codes. If I'll be at your place, I'll be reading ICD-11, not ICD-10, but you have to give in the exam the answer. DSM-5 criteria is not very different from this. So even if you sometimes forget about the DSM-5 criteria of major depressive disorder, most of the things are the same in both, right? Except for few ifs and buts here and there. Mild, with or without somatic symptoms, moderate with or without somatic symptoms, severe without psychotic symptoms, severe with psychotic symptoms. These are the specifiers. The ICD-11 and DSM-5 calls them specifiers. F32 depressive episode, mild, moderate, severe, mild with or without somatic symptoms, moderate with or without somatic symptoms, severe with psychotic symptoms, severe without psychotic symptoms. Recurrent depressive disorders. Current episode mild, current episode moderate, current episode severe, current episode severe with psychotic symptoms, and currently in remission. If person is having two episodes, then it is recurrent depressive episode. There is a time frame in which there is a remission period. Everybody clear? मुझे समझ नहीं आती तुम लोगों का रिस्पॉन्सेज देख के कि मैं ठीक जा रहा हूँ कि मैं गलत जा रहा हूँ, और अगर गलत जा रहा हूँ तो तेज तो नहीं जा रहा।
You are going great. नहीं आप ठीक बता रहे हैं, बहुत समझ आ रहा है आई थिंक।
ओके, ना समझ आए, कोई मसला हो तो रोक देना। ओके, कमिंग बैक. Question was, what is metabolic syndrome? Now, this is a very, very frequently asked question, even in the day-to-day clinical practice. Evaluate the person for metabolic syndrome. He is taking antipsychotic. What is metabolic syndrome? So, a brief description of metabolic syndrome. The symptoms of metabolic syndrome. One, browning of the folds of the skin around the neck, armpits, etc. Right? Browning. So discoloration of the skin folds, right, at various portions of the body. These are the physical symptoms or signs. Fatigue, inability to focus, high blood pressure, low HDL cholesterol, high TGs, and high fasting glucose. Lipid profile, deranged, hyperglycemia, central obesity, जो शायद मुझे भी है, apple-shaped obesity, waist is more than 0.90 for males and 0.80 for females. अच्छा, I was trying to locate it, why this is 0.90 and 0.80 for females. So I will come back with this answer, because this answer is attempted another way sometime forward. So I will cover that as well. So men, apple-shaped, and women are pear-shaped. Pear, जो नीचे से बड़ी और ऊपर से छोटी होती, and men all ground, apple-shaped. Polycystic ovarian syndrome in women or erectile dysfunction in men is considered to be in a metabolic syndrome, right? Folds brown, hyperlipidemia, hyperglycemia, inability to focus and concentrate, central obesity, polycystic disease or erectile dysfunctions, and non-alcoholic fatty liver disease. These are metabolic syndromes. There are some of the symptoms of metabolic syndrome. Now, metabolic syndrome is defined as having at least 3 of the 5. 5 में से 3 होने जरूरी हैं. 1, elevated waist circumference, more than 88 centimeter for women and 102 centimeter for men. Now I was trying to convert it into inches, so I don't know. I failed actually. उस वक्त मैं करने लगा और फिर मैं किसी और काम में चला गया और मैं कैलकुलेट नहीं कर सका. इसको इंचेस में कन्वर्ट कर लीजिएगा. It will be easier for you. More than 88 centimeter for women and more than 102 centimeter for men. मैंने इसको simple रखा हुआ है. More than 90 centimeter for female, more than 100 centimeter for males. 102 और 88, confusing. Elevated triglycerides, TGs more than 150, or drug treatment for elevated triglycerides. Even if person is taking a hyperlipidemic agent and his cholesterol is less than 150, even then it is a positive sign. Low HDL cholesterol, less than 40. Desirable is, again, more than 40. More than 40. Desirable is less than 40 for males and 50 for females. Again, approximately 40 and 50 figure yaad rakhiye. Elevated blood pressure. The systolic 130 millimeters of mercury and diastolic more than 85. Previously, the diastolic was about 100. After some time, they reduced it to 95. These days, currently, it is 85, right? So diastolic blood pressure should not be more than 85. So if it is 90, then it comes in the category of metabolic syndrome. Elevated fasting glucose, which is more than 100 fasting blood glucose. More than fasting 100 blood glucose, less than more than 40 HDL, more than 85 blood pressure diastolic, TGs more than 150, and waist circumference more than 90. These are, and out of these five, three are present, you are having metabolic syndrome. So keep a check. Okay, sorry, I have to move forward. Okay, now another question which was there, and one way or the other asked in various themes and formats in a clinical question. What are the suicide risk factors and what are the protective factors in the suicide? So there are certain factors which leads to suicidal attempt and there are certain factors which you stop you from committing a suicide. What are they? So risk factors: precipitating, predisposing, and perpetuating factors. Precipitating factors: substance abuse, access to lethal arms, life events miserable or bad, death of a spouse, death in a family, having a new baby in the family, lots of responsibilities, financial crunches, this inability to cope with the job stressors, access to lethal and life events. New diagnosis of terminal or chronic physical illness. डायबिटीज डायग्नोज हो गई, लोग उसको दिल पे ले लेते हैं. एक्चुअली कैंसर, अगेन आर्थराइटिस, क्रॉनिक CVAs एंड TIAs, इस तरह की चीज़ें ज़्यादा कॉम्प्लिकेटेड होती हैं, बट अगेन डायबिटीज़ को भी लोग सीरियसली लेते हैं. So moderate risk in people having chronic diseases, moderate risk in life events, but evidence could be high, moderate to high. Substance abuse, very high risk and strong evidence as well. Predisposing factor, neuropsychiatric disorders, any neuropsychiatric disorder, Parkinsonism, family history of suicidal behavior, previous suicidal attempt, adverse childhood experiences, and socio-economic deprivation. These are actually risk factors. Now, what are protective factors? Social support, good social support. अम्मा अब्बा हैं, केयर करते हैं, बीवी है, बच्चे हैं, ख्याल रखते हैं, खाना पीना उठना बैठना उसमें कंफर्ट मिलती है, ऑल्दो कॉम्प्रोमाइज भी हो पर कंफर्टेबल है. Connectedness, you have friends, you have family, you talk to them, you went out, you are able to express yourself, so connectedness. Strong therapeutic alliance. You have somebody around you where you feel comfortable. You can access a मौलवी साहब, सिपारा पढ़ा, उनसे डिस्कशन की, रिलीजन के बारे में बात की, वगैरह वगैरह. If you see our live TV shows, where like again मैं नाम नहीं लेना चाहता, लेकिन पाकिस्तानी टीवी शोज जो पॉलिटिकल टीवी शोज हैं उसमें बड़ी हाइटेंड इमोशनैलिटी एक्सप्रेस किया जाता है, और मेरा ख्याल है कि उनमें मेजॉरिटी पीपल जो हैं दे आर नॉट डिप्रेस्ड. So if you talk too much, you express yourself, you won't be, that is again a protective factor in suicide. Positive attitude towards the mental health treatment, coping skills, problem solving skills, cultural and religious beliefs, biological and psychological resilience. Now, resilience is another big topic, so sometimes maybe I'll be able to cover that as well. Risk factor: mental illness, substance abuse, previous suicide attempt, serious physical illness, family history, specific symptoms, childhood traumas, shame, guilt, despair, aggression, access to lethal weapons, suicide exposure, inflexible thinking, and genes, genetic basis. Protective factors: good social support, connectedness, strong therapeutic alliance, access to mental health care, positive attitude, coping skills, problem solving skills, cultural, religious belief system, biological and psychological resilience. These are protective factors. Another question was, how do you assess suicide? I was teaching in a previous presentation, which is uploaded in the YouTube as well, so you can go through that suicide risk assessment. It's an absolute complete presentation about the suicide risk assessment. उसमें मैंने कुछ स्केल्स वगैरह भी कोट किए थे और बताया था कि वो क्या कर सकते हैं. अगर सुनना हो तो किसी वक्त सुन लीजिएगा. Assessing suicide risk. Always ask. Now, there is a controversy about it in the past. People say, don't ask about the suicide directly because it can increase the risk of the suicide. It never happens like that. If you ask about the suicide risk, direct questioning is important for assessment and management. If you won't ask, you will fail. 3 चीजों पे मैं कैंडिडेट को फेल कर दूंगा. अगर वो सब्सटेंस अब्यूज नहीं पूछेगा, जनरल मेडिकल कंडीशन नहीं पूछेगा, सुसाइड रिस्क असेसमेंट नहीं करेगा. ये 3 चीजें हर पेशेंट में, चाहे वो मैनिक हो, स्किज़ोफ्रेनिया हो, बाइपोलर हो, डिप्रेशन हो, सब में पूछनी है. 1 substance abuse, 2 general physical condition, and 3 suicide risk assessment. No compromise on it. स्किज़ोफ्रेनिया में अगर किसी ने कैटाटोनिया सिम्टम्स एलिसिट नहीं किए, मेरे नजदीक वो कैंडिडेट फेल है. हर स्किज़ोफ्रेनिक पेशेंट में, पेशेंट विद स्किज़ोफ्रेनिया, you have to assess for catatonia. If you haven't done that, fail. Sorry about that, but these are rigid criteria. Ask about the suicide thoughts. Plan lethality means consider the risk of the infant at all times. Fleeting thoughts of self-harm or suicide, but no current plan or means, low risk. Suicidal thoughts and intent, but no current plan, moderate risk. Continual specific suicidal thoughts, intent, and a plan, and means as well, high suicide risk. And if somebody is in a low risk, definitely I can treat them in an outpatient department. But if somebody is having a high risk, he expresses that he is suicidal, these thoughts keep on coming in their minds. They have access to the lethal weapons. They have attempted in the past. They have intent and plan how to go about it. I will definitely hospitalize him and treat him appropriately. So high risk suicidal patient needs to be assessed properly. Okay. There was another question. Psychometric test to assess the cognition or cognitive processing. And so you have to assess them. मेरा ख्याल है, if I'm not wrong, they were asked about related to WAIS, Wechsler Adult Intelligence Scale, and they were asking about the scales in it. I don't remember exactly that this was it or different. I think it was a different question. Types of the test to assess the cognitive assessment, right? Depending upon the time-based, speed test and power test, Kaufman assessment battery for children. Depending upon the number of individuals, group testing, like there are 100 police officers sitting in front of you and you want to assess them for any psychiatric morbidity, you will devise a test, you will give them all 12 question GHQ 12, high scorers will be screened out and assessed furthermore. So type of the, so these are probably, this question was related to the site. What are the qualities, what types of the psychometric tools are available? So depending upon the time, second depending upon the number of people, third depending upon the language, verbal and non-verbal, depending upon the method, paper, pencil, or just tick box or performance, depending upon what is measured, intelligence, aptitude, achievement, personality. 4 किस्म के टेस्ट होते हैं. इंटेलिजेंस टेस्ट होते हैं, एप्टीट्यूड टेस्ट होते हैं, अचीवमेंट टेस्ट होते हैं, पर्सनालिटी टेस्ट होते हैं. पर्सनालिटी टेस्ट की मिसाल हमने पीछे कवर की, MMPI है. इंटेलिजेंस टेस्ट की मिसाल वेज है, वेशलर एडल्ट इंटेलिजेंस स्केल. एप्टीट्यूड टेस्ट की मिसाल सैट, GRE, ये एग्जामिनेशन टेस्ट हैं. और अचीवमेंट टेस्ट आमतौर पे जो एग्जाम के बेसिस पे अचीवमेंट टेस्ट डिवाइस किए जाते हैं. So common examples. Types of the psychometric test, they can be numerical, 1, 2, 3, 4, 5, ठीक है. Mild, moderate, severe, profound, not known. Verbal reasoning, you can ask a question, they can respond, and then you can again write the answers. Inductive reasoning, you assume things from the responses. Diagrammatic reasoning, you ask them to make a clock, draw a clock, and then you assess how much the clock was refined and appropriate, and then you reason out. Logical reasoning, you give them certain questions and they have to attempt it. Aptitude tests are based on it. Logical reasoning. Error checking, so you give them clues to reach to some conclusion. If they are not able to reach to a conclusion, that is an error, and you check how many times the error was made. Okay. Somebody came in or went out. I don't know. Okay. Everything's okay? Okay, there was a hand raised. Don't raise hands. I'm not able to see that. Just ask it. Stop me. Don't worry about it. Panic नहीं करना. पूछ लो सवाल. किसने हाथ उठाया हुआ है? Somebody wants to ask any question? Anybody? Nobody? Sure? Or you can type in the chat box so I can respond it. Okay. अश्क आंखों में छिपाते हुए थक जाता हूँ, बोझ पानी का उठाते हुए थक जाता हूँ. Very depressing. Last for today. Okay. Full scale. I think this is ways. Verbal comprehensive index scale, core subtests, similarities, vocabulary, information, supplemental subtests, comprehension, working memory index scale, core subtest is digit span, arithmetic, supplemental subtest, letter number settings, sequencing, perceptual reasoning index scale, core subtest, block design, matrix design, visual puzzles, supplemental subtest, figures, weights, and picture completion, processing speed index scale, symbol search and coding, and supplemental subtest cancellation 16 to 69 only. This is the full scale of, I think, ways. Usme various subscales or wo mention everything theoretical, just go through it. Okay, so I think I should stop here. This is the next question. What are the structures of the brain and what type of things they control in humans, and what kind of the treatment or assessment strategies you have to opt for it. So this slide we will start from next week. Tomorrow, sorry, next week, yeah, tomorrow. Any question? Anybody?
Sir, one information required. Sir, there has been a lot of discussion today in our IMM group के जो pattern है वो अचानक से शायद change हो जाए, and there might be MCQs. There was an information from Peshawar. So do you have any information regarding this?
The MCQ bank was built up with the hope that it will be implemented soon. This was going on for past 3 years. 3 साल से डिस्कशन हो रही है कि बल्कि 3 साल से डिस्कशन क्या हो रही है कि College of Physicians and Surgeons ने they have made it compulsory for most of the specialty to go for MCQs rather than SAQs, short answer questions. And its implementation was unfortunately compromised because of multiple other reasons in psychiatry. Even if it changes to MCQs, you'll be in a good frame of mind. It will be easier for you to manage these questions and attempt them. So don't panic. Unless or until it comes like MCQs, don't panic. It will be easier, not difficult. So the MCQ bank was actually again not good enough to go for MCQ test. लेकिन अभी मुझे कोई इन्फॉर्मेशन नहीं है कि ये MCQs पे जा रहे हैं. लेकिन जब बात ये 3 साल 4 साल से हो रही है MCQs पे जा रहा है, वो 6 साल से हो रही है कि MCQs पे जा रहे हैं. Maybe not. I'll check it out. If I'll get some information related to it, I will definitely update you people. I think कराची से लोगों को बेस्ट इंफॉर्मेशन होगी. अगर कराची में जो आपके साथी हैं वो ये इंफॉर्मेशन बेस्ट दे देंगे. हो जाए तो मुझे भी बता देना, मैं भी पूछता हूँ, आप भी पूछो. और